I call it sort of the last mile problem, to plagiarize a phrase from other contexts, where basically in these communities there really is no clinical services available to these villagers. I'm sure all of you have heard, seen, or read about women, for instance, carrying their sick child on her back for hours and hours to a clinic, only to find that possibly the clinic is closed, or that the clinician is not there that day, or that the drugs are not there, or that there is a fee that's charged at the door and cannot be afforded by the mother of the sick child. So what we're working with the communities to do is to assess what would it take to have a basic core of clinical interventions available within reasonable walking distance of each family. And we do this needs assessment. When I say we, by the way, as I'm sure other speakers have talked, we don't actually do anything. All the work is done by the local and certainly national counterparts, and the Millennium Village staff, technical experts such as agronomists and hydrologists or public health people like myself are advisors, and don't actually, of course, make any of the ultimate interventions. That's all based on community decision process and collaboration with the regional, in my case, regional health officials, and also ultimately, again, in health, with the Ministry of Health. So all of these discussions, plans, and interventions are done with in a collaborative manner, first and foremost discussing it with the community, having them articulate what their needs are and what it is that they can put in to the construction of some of these interventions, and then discussing it with the regional officials, regional officers, what it is that they can do from their regional funding and expertise. And then we help, the Millennium Village Project comes in with some of the real gaps, basically some of the gaps due to lack of funding. So what is it that we help the communities think about is basically, as I said, the last mile problem. We work with them to help build infrastructure such as a clinic. We make it a sort of a gold standard that there should be a clinic for every 5,000 people or so, that there should be a clinic within no more than at most 2-hour walking distance from every villager, that the clinic should be staffed, equipped, and have the appropriate drugs that do address the problems that are seen in that community. The other thing that we work with the villages to do is to identify the referral hospital, the rural hospital that the clinic would be referring their sicker patients to, and make sure that that hospital is equipped to take care of the more serious problems. In all of the countries that we work in, the referral rural hospitals are basically not functioning properly because they have frequently no electricity, no water, no clinician, no surgical room, no equipment, no drugs. It's really quite a complicated situation. So in the Millennium Villages, we start with making sure that the referral rural hospital, which usually serves about 100,000 people or so, we help them with making sure that there is a clinician 24 hours a day, that there is an operating theater, that there is running water, electricity, and the gold standard of, I would say, of a rural referral hospital is that it's capable of doing a cesarean section in what we call emergency obstetric care for a woman who is in obstructed labor. So there's a referral hospital which should be able to handle simple surgical procedures. There's a clinic that services about 1,000 people. And then the third component, which is very, very important and has been proven to, in the short term, make a huge impact on child mortality, is the community health worker that all of you certainly know about. The community health worker is usually a local person, so it's not there isn't an issue of the brain drain, which is of course impoverished African public health system of its wonderful, well-trained doctors, 50% of whom leave immediately after graduation because they have a global commodity that they can go anywhere with. The community health workers are local people who stay put, and for the time being, in most countries, the community health workers are volunteers that are working just a few hours a day because they don't make any money, so they have to have other form of livelihood. The farmers typically. They're volunteers, they're not supervised, they're not managed, they don't really have the prerequisite equipment, they often don't have any therapeutic drugs. So what we're working with the communities to do is to empower these, to professionalize the community health worker force. And this has become an effort that's actually been pretty much accepted by many international organizations and of course also the WHO, that it is critical for the immediate well-being and health of the community to have professionalized community health workers, meaning that they're remunerated, they're part of the Ministry of Health, they are properly trained, and that they're supervised, managed, and that they're held accountable for their work. This community health worker has been shown over and over again in many countries. One classic case study is the Navrongo study in Ghana, the health extension work in Ethiopia. These community health workers, once empowered with the tools, with supervision, with skill set, can really make a huge difference because they operate at the community level, at the household level, which is where most of the problems are, which is where most of the deaths take place, is right in the household. And these community health workers, once they have taken on this more comprehensive skill set and curriculum training, can actually do quite a lot of things at the household, which has been also done, of course, for many decades, but with these supports can be improved. So they can do, of course, preventive measures. They can discuss with a newborn mother of a newborn about feeding, child nutrition. They can discuss family planning. They can discuss personal hygiene and sanitation. So there are a lot of preventive and promotive kind of services that they can render. And we contend that they can also do, and it's also been proven in some small scale projects, they can also handle some of the very basic diseases in a therapeutic manner. So for instance, they absolutely can handle diarrhea, which, as we discussed before, is a major cause of morbidity and mortality. So they can handle ORS, the oral rehydration solution, with zinc, which is a lifesaver for a child with diarrhea. They can handle malaria. All children under 5 that have fever should be treated with anti-malaria drugs, and the community health workers can, and in many instances do very successfully, treat with artemisinin combination therapy, the anti-malaria drug, treat patients right in their household. So there really is quite a lot of preventive, promotive, and therapeutic services that a community health worker can do at the household level. So basically what in the Millennium Village Project, what we're doing is we're sort of extending the public health sector, working with the community and the regional district officials to extend the health services from the sub-district, which is usually where they end, down to the household level. And the close-to-client component is extremely important, taking care of the family in their home. By the way, one critical component of the public health intervention is that all medical care has to be free and is free in the Millennium Villages, and of course we're advocating for it continent-wide because it's been shown that obviously any form of payment, as little as it may be, is a deterrent. And the first and foremost main intervention that you all know